Let's delve into the complex world of obsessive-compulsive disorder, OCD, and explore its manifestations, diagnosis, and management. Obsessive-compulsive disorder. Obsessions are characterized by recurrent, persistent, intrusive, and unwanted thoughts, images, or impulses that cause significant distress to the individual. These thoughts are often irrational and beyond the individual's control. Compulsions are ritualistic or repetitive behaviors or mental acts that individuals feel driven to perform in response to their obsessions. These behaviors are carried out in an attempt to neutralize or alleviate the anxiety caused by the obsessions. Common compulsions include checking rituals, counting rituals, washing or scrubbing, praying or chanting, touching or rubbing, ordering or arranging, exhibiting rigid performance, and experiencing aggressive urges. A diagnosis of obsessive-compulsive disorder, OCD, is made when obsessions or compulsions consume the individual to the point where they interfere with personal, social, and/or occupational functioning. Despite recognizing that their thoughts or behaviors are unreasonable, individuals with OCD find it challenging to stop or control them. OCD can onset in early childhood, with symptoms often persisting into adulthood if left untreated. In females, it more commonly begins in the 20s. Individuals with OCD may experience periods of waxing and waning symptoms throughout their lifetime. There are differences between early onset and late onset OCD, with variations in symptom severity, response to treatment, and functional impairment. Treatment for OCD typically involves a combination of cognitive behavioral therapy, CBT, and medication. CBT techniques, such as exposure and response prevention, ERP, help individuals confront their fears and reduce the urge to engage in compulsive behaviors. Medications, such as selective serotonin reuptake inhibitors, SSRIs, are often prescribed to alleviate symptoms of anxiety and depression associated with OCD. In addition to obsessive-compulsive disorder, OCD, there are several related compulsive disorders characterized by repetitive behaviors that individuals feel driven to perform. These include self-soothing behaviors such as excoriation, skin picking, trichotillomania, hair pulling, and onychophagia, chronic nail biting. Body dysmorphic disorder, BDD, which involves obsessive preoccupation with perceived flaws in physical appearance. Hoarding disorder, characterized by persistent difficulty discarding possessions regardless of their value. Reward-seeking behaviors such as kleptomania, compulsive stealing, oniomania, compulsive buying, and body identity integrity disorder, BID, in which individuals experience a strong desire to amputate a healthy limb. Etiology of OCD and related disorders. The etiology of OCD and related disorders is multifaceted and involves both genetic and environmental factors. The cognitive model, based on Aaron Beck's cognitive approach to emotional disorders, suggests that childhood experiences and environmental factors play a significant role in the development of these disorders. Additionally, heredity plays a role, with a complex network of several genes contributing to the genetic risk for OCD. Cultural considerations. While the symptoms of OCD and related disorders are fairly similar internationally, there may be variations in symptom expression or beliefs about symptoms across different cultures. Highly religious individuals, both Christian and Muslim, may experience a heightened sense of personal guilt, which can exacerbate symptoms. In some cultures, individuals with OCD may attribute their symptoms to supernatural causes, which can influence their treatment-seeking behaviors. Pharmacologic treatment may also vary significantly across cultures, depending on cultural beliefs and practices. Treatment. Treatment for OCD and related disorders typically involves a combination of medications and therapy. Selective serotonin reuptake inhibitors, SSRIs, such as fluvoxamine and sertraline, are considered first-line medications for OCD. Serotonin norepinephrine reuptake inhibitors, SNRIs, such as venlafaxine, may be used as second-line options. In cases of treatment-resistant OCD, second-generation antipsychotics like risperidone and aripiprazole may be prescribed. Behavioral therapy, particularly exposure and response prevention, ERP, is an essential component of treatment for OCD. ERP involves deliberately confronting situations and stimuli that the client usually tries to avoid, while simultaneously preventing the performance of rituals. By learning to tolerate the associated thoughts and anxiety without engaging in compulsive behaviors, individuals can gradually reduce their symptoms and improve their quality of life. OCD and nursing process application. Assessment. Assessment of individuals with OCD involves using screening tools specifically designed to identify symptoms of the disorder, gathering a comprehensive history, observing the individual's general appearance and motor behavior, and assessing mood, affect, thought processes, and content are essential components of the assessment process. It's crucial to pay attention to how individuals describe their obsessions, as they may report feelings of anxiety and powerlessness. Additionally, evaluating judgment, insight, self-concept, roles, relationships, and physiological and self-care considerations, such as sleep disturbances and changes in appetite and weight, provides valuable insights into the individual's condition. Common problems associated with OCD include anxiety, ineffective coping, fatigue, low self-esteem, and skin breakdown. Identifying these problems helps prioritize interventions and develop individualized care plans. Outcome identification. Setting realistic and achievable goals in collaboration with the individual is essential for effective care planning. Goals may include reducing anxiety levels, improving coping mechanisms, enhancing self-esteem, and maintaining skin integrity. Actions. Interventions for individuals with OCD focus on promoting therapeutic communication, teaching relaxation techniques, implementing behavioral techniques, ensuring completion of daily routines, and providing education to the individual and their family members. Therapeutic communication involves actively listening to the individual's concerns, providing empathetic support, and validating their experiences. Teaching relaxation techniques such as deep breathing exercises and progressive muscle relaxation can help individuals manage anxiety symptoms. Behavioral techniques such as exposure and response prevention, ERP, help individuals confront their fears and reduce compulsive behaviors. Ensuring completion of daily routines such as hygiene and self-care activities helps maintain a sense of normalcy and routine in the individual's life. Education about OCD and its management helps individuals and their families understand the disorder and participate actively in treatment. Evaluation. Evaluation involves assessing the effectiveness of interventions in achieving the identified goals and making adjustments to the care plan as needed. Monitoring changes in symptoms, coping strategies, and overall well-being helps track progress and guide further interventions. Client-family teaching. For clients, educate about OCD. Provide information about the nature of OCD, including the cycle of obsessions and compulsions, and reassure the client that they are not alone in their experiences. Encourage open communication. Emphasize the importance of talking openly about thoughts, feelings, and experiences related to OCD with healthcare providers, family members, and support groups. Emphasize medication compliance. Stress the importance of taking prescribed medications as directed by healthcare providers to help manage symptoms and improve overall functioning. Teach behavioral techniques. Provide instruction on behavioral techniques such as exposure and response prevention, ERP, which involve gradually confronting feared situations or objects without engaging in compulsive rituals. Emphasize tolerating anxiety. Help the client understand that learning to tolerate anxiety without resorting to compulsive behaviors is a key component of treatment for OCD. For families, avoid giving advice. Encourage family members to refrain from offering unsolicited advice or trying to solve the client's problems, as this may inadvertently reinforce compulsive behaviors. Avoid trying to fix the problem. Teach family members to provide support and encouragement without attempting to eliminate the client's obsessions or compulsions themselves. Practice patience. Emphasize the importance of patience and understanding in supporting a loved one with OCD, as recovery is often a gradual process that requires ongoing support. Monitor anxiety levels. Encourage family members to pay attention to their own anxiety levels and seek support or take breaks when needed to prevent burnout. Self-awareness issues. Understand the chronic nature of OCD. Help clients and family members recognize that OCD is a chronic condition that may require long-term management and support. Acknowledge clients' awareness. Validate the client's awareness that their thoughts and rituals interfere with their daily life, and encourage them to seek help and support to address these challenges. In conclusion, client and family teaching are essential components of caring for individuals with OCD. By providing education, support, and encouragement, healthcare providers can empower clients and their families to effectively manage symptoms and improve quality of life. Additionally, fostering self-awareness about the nature of OCD helps clients and families navigate the challenges of living with this chronic condition. Thank you for joining me in this discussion of client and family teaching and self-awareness issues related to OCD. Don't forget to like, subscribe, and share this video for more nursing insights.